Thank you for answering the pretest. I am Dr. Sarabet De Castro, a member of the Philippine Pediatric Society, Southern Tagalog Chapter, and a pediatric gastroenterologist. Welcome. Tukain na, please. Eeny, meeny, miny, mo is a simple counting rhyme that is common to us and common to our children. But, can this be as simple as we deal with the difficulties in feeding children? Or are we dealing with the difficult rhyme of feeding disorders? The objectives will be as follows. Explain feeding disorders according to their prevalence, manifestations, classification, and its subtypes. Explain the approach in patients with feeding disorders. Enumerate the organic and behavioral red flags. And lastly, apply different approaches in management among children with identified feeding disorders. From the moment of birth, a child begins to assert independent functioning and now needs to receive nutrients by the process of being fed. Feeding differs from eating, as feeding plays a central role and it involves an interaction between the child and the caregiver. The caregiver is responsible for what,
when, and where to eat, while the child is responsible for how much and whether they eat. While eating will only reflect the child's actions.
In children, feeding disorders have different etiologies, and the interaction may be unpleasant and difficult for both parents and children. It is common among infants and children below 6 years of age. Feeding disorder is defined as a severe problem that results in substantial organic, nutritional, or emotional consequences. It may present as a food refusal or lower amount of food intake than the appropriate for age. It can be due to behavioral issues or secondary to organic conditions. Feeding disorders may appear as an isolated problem, a negative behavior during feeding, or as a concomitant disorder with an underlying organic disease or structural abnormality. Several classifications of feeding disorders have been published since 1998, but we will focus in the most recent classification made by the group of Chator in 2015. It is the first classification that include the feeding style presented by the feeder as responsive, controlling, indulgent, or neglectful. Parents of young children worldwide are concerned about feeding difficulties. When asked, more than 50% of mothers claim that at least one of their children eats poorly. This implicates around 20 to 30% of children as shown in this diagram. But still, majority of these children are still classified as having normal feeding. These disorders are of concern for over 10 to 25% of parents of otherwise healthy children below 3 years of age, but only 1 to 5% of infants and toddlers suffer from severe feeding problems resulting in failure to thrive. Feeding problems occur in 30% of preterm infants, but highest up to 80% among patients with neurological impairments. In evaluation of patients with feeding difficulties, there are 5 important elements or questions we need to answer or identify. As we discuss in the next few slides, the approach in identifying feeding disorders. How is the problem manifested? Is the child suffering from any disease? Have the child's weight and development been affected? What is the emotional climate during child's meals? And lastly, are there any great stress factors in the family? Common features seen among patients with feeding difficulties are prolonged meal times, food refusal lasting for 1 month, disruptive and stressful meal times, lack of appropriate independent feeding, nocturnal eating in infants and toddlers, introducing distractions to increase intake, prolonged breast or bottle feeding in toddler or older child, failure to introduce advanced textures. There are different manifestations of patient with a feeding problem. These are gagging or lumpy food, limited food preferences, pocketing food in the cheeks, spitting food out, weak sucking or chewing skills, slow progression to table foods. How are we going to approach a patient who presented any of the following symptoms? Initial evaluation of patients with feeding disorders begins with a pediatrician. The parental concern about child's feeding will be the initial reason why they sought consult. Most parents of these children were described as frustrated and distressed at mealtime. A thorough history and complete physical examination is warranted in initial evaluation. Review of the medical history and family history, including the child's prenatal and birth history, is necessary. When it is apparent that a potential feeding difficulty exists, a detailed feeding or nutritional history and carefully assessing the nutritional status are vital. And prompt attention should focus on the presence of the red flags, which can be of organic and behavioral in origin. Organic red flags are the following. As pediatricians, we must know that the presence of red flags will signify an organic disease or underlying pathology. The most important will be dysphagia and aspiration. Dysphagia may implicate esophagitis that can be due to gastroesophageal reflux, eosinophilic esophagitis, infections, or toxic injury. Aspiration or recurrent choking or recurrent pulmonary infection may suggest the possibility of a poorly coordinated swallowing, which is commonly seen among children with developmental limitations and neurologic disorders such as cerebral palsy. Organic feeding disorders are those resulting from organic disease. They should be properly recognized and treated according to the basic problem. Again, the most critical red flags in organic feeding disorders are dysphagia and aspiration. The pediatric conditions that are associated with feeding disorders are prematurity, genetic or chromosomal abnormalities, craniofacial anomalies, acquired brain impairment, gastrointestinal disorders, and neurodevelopmental disorders. How about the behavioral red flags? The following are the behavioral symptoms that require prompt attention: food fixation, harmful feeding, abrupt cessation of feeding after a trigger event, anticipatory gagging, and lastly, failure to thrive. In non-organic feeding disorders, children show incorrect feeding behaviors without underlying organic disease. But in some cases, behavioral problems may coexist and often add to the organic problem. The most serious complication with this type of feeding disorder is failure to thrive, which can be secondary to poor caloric intake. Our primary concern is the identification of children whose poor appetite is due to an underlying organic disease. Further investigations for the specific organic etiology in mind will be necessary in order to address the problem. However, in children with no organic disease identified, we should consider the following types of feeding difficulties. Let us discuss the first two types. first classification is limited appetite with subtype parental misperception. Parents believes that the child's appetite is limited when it is appropriate. The child is small but achieves satisfactory growth. The primary risk for these children is the excessive parental concern that leads to coercive feeding methods that may adversely affect the child. In 2004, Saari Leto studied over 400 children in which 30% were described by their parents as poor eaters. They used parental evaluation using questionnaires that results intake was equivalent to normal eaters and appropriate to meet the nutritional needs. The approach in managing patients with parental misperception of limited appetite should focus on educating parents and other caregivers about appropriate expectations for growth and nutrition, teach them on the basic feeding practices or guides, and the importance of applying these principles consistently. Never use force or coercion. Lessen the parents' fear about nutritional inadequacy of their child by explaining to them that the growth of their child is adequate. Next subtype is energetic active child. Children are active, energetic, curious, and far more interested in playing or interacting with people than eating. They refuse to remain seated during meals and eat small amounts, around 1 to 2 bites only. The hallmark of this subtype is the conflict between the parent and the child, and if unresolved, this may hinder the child's ability to reach the optimal cognitive potential. This reflects conflict at home rather than the low nutrient intake. Chatur et al. Describe these children as having infantile anorexia. It is evident during the transition to self-feeding between 6 months to 3 years of age. In an energetic child with limited appetite, the goal is to increase appetite by promoting hunger and then allows subsequent satisfaction from eating. As pediatricians, we should emphasize the feeding schedule that encourages hunger. A maximum of 5 meals including snacks per day without nothing but water in between. It is also important to minimize distractions during feeding. Parents must also model healthy eating, adhere to the feeding schedule, set limits for mealtime behavior, including appropriate discipline. Parents should also offer attention in response to positive eating behavior. However, growth failure associated with poor appetite often necessitates enriching the diet calorically and addition of nutritional supplements. How about in an apathetic child? Limited appetite in a child that is inactive, not interested in both eating and their environment, or sometimes they communicate poorly with the caregivers. The limited appetite of these children is part of an overall withdrawal in which smiling, babbling, or even eye contact are not discernible. These children are at risk for substantial weight loss and malnutrition. Chatur described this feeding problem as disorder of reciprocity because there is the breakdown in the communication of the mother and the child. Providing adequate nutrition is important. It is also characteristic for withdrawn children with limited appetite to respond positively to an enthusiastic and experienced feeder. In some cases, excellent results have been obtained with hospitalization to provide a positive feeding environment. Second classification is selective intake. Neophobia is often misperceived by parents as inappropriate selectivity. However, it is a normal behavior. It is associated with adaptive evolutionary conditioning of the child. They start to reduce number of variety of foods and low consumption of meat, vegetables, and fruits. But with repeated exposures, this eventually resolves. It begins at the first year of life and peaks between 18 to 24 months. With misperception, educating the parents to have a reasonable expectations and counseling them to consistently and repeatedly expose children to new foods. Food must be offered 8 to 15 times without pressure to achieve acceptance. Children with mild selectivity includes a large group and often referred to as picky eaters. They consume fewer foods than average. In 2003, Jacobi made a study defined by their parents as picky. Results showed that there is high incidence of subsequent behavioral problems including anxiety, depression, aggression, and delinquency, and these are consequences of coercive feeding of parents towards these children. Aside from repeated exposures, the other simple techniques will include hiding puree vegetables in the sauces, use dips to enhance flavor, giving of foods with appealing names, and involving children in food preparation and present in an attractive design. The next subtype under selective intake is high selectivity. Children usually limit their diet to 10 to 15 foods. They consistently refuse specific food due to taste, texture, smell, or appearance. It is also known as the sensory food aversion, a refusal to eat whole categories of food related to the taste, smell, temperature, or appearance. Some children may also have additional sensory difficulties such as responses to loud noises or bright lights. It can interrupt developmental of normal oral motor skills, and up to 90% of children with autism have feeding problems classified as highly selective. Management of these children will include explaining to parents that the feeding difficulty is part of a broader sensory condition. Fundamental principle is not to push children to eat, but this will require a more intense and systematic approach. Replacement of one food with a similar one or food chaining is effective. In more severe cases, altering the taste, color, texture, and exposure to food, also known as fading and shaping, can be done. Supplement the diet may be necessary to ensure a balanced intake. We are left with the last two classifications: fear of feeding and feeding style. Any severely aversive feeding-related experience may cause fear of feeding. These are three patterns identified by Chator: fear of feeding after a single event like choking, fear of feeding in the young who has been subjected to painful, unpleasant oral procedures, and fear of feeding in children who are tube-fed. Infants with excessive crying is misperceived to be hungry and fearful of feeding, as they resist the bottle or the breast. But most of them are crying because of other reasons, and in most cases, these children are receiving adequate amount of food. In older children, fear of feeding is seen among those who chokes, gags, or vomit food and then ceases to eat. They are also termed as functional dysphagia, choking phobia, or phagophobia. The main goal is to reduce anxiety associated with feeding or eating. Reassurance with positive reinforcement is the main key, especially to those with misperception. As pediatricians, we must identify if there is actual fear of feeding. A systematic approach is needed to resolve the pain and decondition the infant's fear, though in severe cases, cognitive behavioral therapy may be necessary. The parent's action altered the child's feeding behavior. Therefore, caregiver feeding styles is an essential part of management. Parental feeding practices are based on four well-described feeding styles, namely responsive, controlling, indulgent, and neglectful. Responsive is the preferred style. However, controlling, indulgent, and neglectful generally have negative consequences. These styles are influenced by the norms, parental concern, and child's characteristics. Responsive feeders follow the concept of responsibility. The parent determines where, when, and what to eat, while the child determines how much to eat. The parent guides the child's eating instead of controlling it. The parent set the limits, model appropriate eating, and talks positively about food. Controlling. It is common among caregivers. They use force or punishment or inappropriate rewards to coerce the child to eat. Indulgent. They fed the child whenever and whatever the child demands. This may result in lower consumption of appropriate food. Lastly, neglectful. Abandon the responsibility of feeding the child. This may sometimes feel abandoned or detached, as the parents ignore the child's hunger signals or emotional needs. In severe cases, this may result to failure to thrive. We as pediatricians should identify the feeding style of the parents. We should adjust our instructions based on their feeding styles. We must help them understand that they should be a responsive feeders. For controlling parents, they should be guided to offer food in non-coercive way. However, for indulgent and neglectful parents, they should be structured and precise. A careful understanding on the effects of these feeding styles should be emphasized to the parents because it can end up with a negative behavioral consequences to the child. Dealing with feeding difficulties will always be a challenge to us, but these feeding guidelines will be of big help as we battle the feeding disorders. Avoid distractions during meal times. Maintain a pleasant neutral attitude throughout meal. Feed to encourage appetite. Limit meal duration 20 to 30 minutes. And give 4 to 6 meals or snacks per day with only water in between. Serve age-appropriate foods. Systematically introduce new foods up to 8 to 15 times. Encourage self-feeding and tolerate age-appropriate mess. Proper therapy is still effective with a success rate of 90%, and it mainly depends on the underlying cause. However, we must remember that early recognition of the problem and offering the basic support for the parents to achieve good outcome are the responsibility of every pediatrician. In summary, we have discussed feeding disorders, identified the different manifestations of children with feeding difficulties. We also went through the approach among these patients, discuss the different classification and its subtypes, and lastly, the management for each classification of feeding disorders as well as its prognosis. Feeding disorders may be defined, classified, or identified in different ways, but it can be as eeny, meeny, miny, mo, a simple rhyme for us pediatricians to deal with. Thank you and have a good day. All for the Filipino child.